Hello, everyone, and welcome to the Science of Childhood Cancer lecture series hosted by the St. Jude Comprehensive Cancer Center. I'm Melissa Hudson, co-leader of the Cancer Survivorship and Control Program, and on behalf of myself and my co-program leader, Dr. Les Robinson, we welcome you to the last lecture of this 15-week series and our third survivorship talk. This virtual series has been a new experiment during this time of COVID, and there has been tremendous engagement with more than 3,000 registrants and attendees participating from all over the world. So it's my pleasure today to welcome Dr. Eric Chow from the University of Washington and the Fred Hutchinson Cancer Center. Dr. Chow has kindly offered to stay on for some time after the official close of the event at the top of the hour if anyone would like to stay for further discussion. And now I'm pleased to introduce Dr. Eric Chow, who is an associate professor in the Department of Pediatrics at the University of Washington and in the Clinical Research and Public Health Sciences Division at the Fred Hutchinson Cancer Research Center. He also serves as medical director of the Cancer Survivorship Program at Seattle Children's Hospital. Dr. Chow is a well-known expert in cancer survivorship, as evident by his multiple leadership positions, which include currently serving as chair of the Children's Oncology Group Outcomes and Survivorship Committee, vice chair of the National Wilms Tumor Late Effects Study, co-chair of the Childhood Cancer Survivor Chronic Disease Working Group, member of the ASCO Survivorship Guideline Advisory Group, and member of the Center for International Bone Marrow and Transplant Research Late Effects Committee. Dr. Chow's research has broadly focused on characterizing outcomes of survivors of childhood cancers and those treated with stem cell transplantation, identifying risk factors for cardiovascular complications in cancer survivors, which he has translated into risk prediction models to facilitate survivorship care, and evaluating clinical trials of health-promoting interventions in this population. We are delighted that Dr. Chow has accepted the challenge to wade into uncharted waters and provide us with a lecture about emerging late effects of targeted molecular therapies. So I'll turn the podium now over virtually to Dr. Chow.
Melissa and Les, of course, thank you very much for this opportunity to share as much information as I know. For those on the call, if any of you the summer of 2019's North American Late Effects, Childhood Cancer Late Effects Symposium, some of the slides are going to be from that as well. But for those that didn't attend that meeting, hopefully you'll find this interesting and engaging. This is our the outline of today's talk. Some disclosures. I actually have none, but I'm also not an immunologist, nor am I in developmental therapeutics, which a lot of this talk will talk about. So just as a brief background, since I'm not entirely sure what the distribution of the audience is, but just to get people on the same page, 5-year survival among children, at least in the U.S., has increased, tremendously over the last, 50 years or so. In the 1970s, we saw increased chemotherapy intensity, introduction of bone marrow transplantation, the reduction of radiation for some cancers. In the 1980s, we saw a further reduction, some new chemotherapy agents being developed and utilized, such as some of the ifosfamide or cisplatin agents. In the 1990s, I think there was appreciation for increasing molecular subtypes of disease and more refined risk categories. In the 2000s, we saw increased genomic knowledge being applied, drugs designed to target specific cancers, such as arsenic for APL, imatinib for CML and Philly-positive ALL, dinutuximab with neuroblastoma, Malatar gemtuzumab for AML, and rituximab for a variety of B-cell malignancies. And then the most recent decade that's, of course, has ended, we saw the advent of genetic engineering and a growing number of molecular targeted agents. This is just a figure from a number of years ago. So now I'm sure it's even gotten more complex, but obviously there's a lot of various targets, both on the cell surface and internally, that have been found to contribute to oncogenesis, of which there are a growing variety of agents that target at least one of these pathways, or in some cases, multiple pathways shown here. These are just some of the examples. These are some agents that have been linked to these particular targets. Of course, that number has grown quite a bit in the last 5 to 10 years. So with that in mind, we'll talk a little bit about the known toxicities. I've broken up into several domains that have been a little bit better characterized, including financial toxicity. And then we'll touch on, but really not really do justice, but obviously this is not just advances in, from the field of pediatric or medical oncology, but certainly there have been significant advances in surgery as well as radiation oncology that I'll touch on. But those by themselves can be, I think, probably whole hour lectures as well. Just taking a step back in time, this is a paper from 1967 where they introduced donomycin as a new anti-tumor antibiotic for cancer treatment, especially in this case for childhood leukemia. And note that David Karnofsky was the senior author on this paper. 10 years later, there are reports of donomycin-induced cardiotoxicity in both children and adults, where they reviewed a series of 110 cases. Similarly, this is 1957. We saw some of the first reports of bone marrow transplantation being potentially effective. And then several decades later, there are now papers on growth and development abnormalities in children treated with bone marrow transplantation who have since grown up. Of course, in the more recent century, we saw New England Journal papers that introduced the seminal efficacy of imatinib as a BCR-ABL tyrosine kinase inhibitor with CML. We've seen anti-GD2 or dinutuximab in conjunction with IL-2 and retinoic acid for neuroblastoma. And then more recently, CAR T cells for ALL and other hematologic malignancies. So how targeted are these agents? Are there unintended consequences? What are their late effects? And really, when will we find out more? Will it be in 10 years or in 30 years? And so the current state of knowledge, especially with relation to pediatric oncology, is essentially still, I think, a black box. There's limited data. Most of the data are in adults. And what data that tends to exist still tend to be on acute toxicities. And for the most part, I think we are unclear what the long-term effects may still be. That said, we continue to learn new things about treatments that have been used for decades. So I think it's important to stay humble in that what we think we know, even of the drugs that we've been using for 30 or 40 years, we're still gaining more knowledge. So with that, I think I'll conclude my talk. And for those of you who saw this talk last year, obviously this is a joke. But that essentially could be the talk. But really what we know is that this potentially can be a Pandora's box, where we have seen, at least in the short term, a variety of unintended effects, such as autoimmunity, certainly hypogammaglobulinemia, immune dysregulation, bone and growth defects, especially in children who are still growing compared with adults. There may be a signal for new cancers for certain agents, cancer induction. And then, of course, I mentioned financial toxicity. Worse things can be as well. And again, this was a movie that I think came out about 20 years ago now. And in this movie, where Will Smith is the protagonist, scientists genetically re-engineered a measles virus in order to cure cancer. The virus then mutates and kills off the majority of the world's population. A very small proportion of humans we have an intrinsic mutation akin to something like CCR5 mutation for HIV. And the remaining 10% of humans are transformed into these zombie vampire mutants that kill most of the resistant humans. Of course, then Will Smith as protagonist discovers a cure for the virus. Truth is stranger than fiction. So now, of course, that was 2019. And of course, we all know what's happened in 2020. And in fact, there's a movie out, which I learned about just yesterday called Songbird, which is apparently about the state of the world in 2023 after 4 years of lockdown for COVID, because COVID has mutated and I guess is not responsive to whatever vaccine has been put out. So truth is stranger than fiction. I think it's important to keep an eye out for late effects that may be unintended, as we don't know what we don't know. So among those agents that I mentioned earlier, with the Will Smith movie in mind, with the affected humans, there are a variety of things that we can think about. There's for some of the CD3, CD19, CD30 CAR T cell products, certainly we've all seen syndrome and also neurotoxicity. So this unfortunate person certainly is neuropathic, it appears. We also have seen some growth, cardiovascular, and thyroid issues with BCR-ABL targeted agents. Crizotinib with pulmonary embolus, so this person is having a hard time breathing. We've seen with VEGF inhibitors, cardiovascular, thyroid issues, and wound healing, as documented in this picture as well. Hepatotoxicity was in inotuzumab and gemtuzumab that are primarily liver cleared in the liver. And so this person is clearly jaundiced. BRAF inhibitors with skin cancers. This movie were very sensitive to light. And then moving on to the variety of other targets, there's other agents or other side effects as well. I've listed a lot of them here. The ones in red, if you can see it clearly, are those that are not mentioned in the previous slide, but are still important as well. And these include B-cell aplasia with some of the CD19, CD20 products, thrombosis with HDAC inhibitors, cardiac dysfunction retinopathy with MEK, MAPK inhibitors, and then with some of the PD-1, CTLA-4 checkpoint inhibitors, we certainly have seen autoimmunity both from endocrine and cardiac standpoints. So moving on to cardiovascular, the heart has certainly been documented to have a variety of side effects. We've seen arrhythmia with ALK inhibitors, arsenic, BRAF, CDK, HTAC. Ventricular dysfunction has been noted in probably a different mechanism from anthracycline-associated cardiomyopathy. This includes both with BCR-ABL inhibitors as well as the other ones listed there, and most notably with HER2 ERB-BB2, which is trastuzumab, which of course is mainly used with breast cancer, but has been also tested with osteosarcoma, which expresses that as well. Ischemia has been reported as an unexpected but a significant late effect with certain BCR-ABL inhibitors such as ponatinib. And then myocarditis, as I mentioned, has been associated with immune dysregulation associated with checkpoint inhibitors. Vascular events have been reported, again, somewhat unexpected, as that profile seemed to be significant with imatinib, but has been seen with ponatinib primarily as a later generation tyrosine kinase inhibitor. Venous thrombosis with VEGF, and a variety of different pulmonary side effects have been reported, including pulmonary embolus as well as pleural effusions with a variety of different agents. And then hypertension has been well documented with VEGF inhibitors such as sorafenib, such that induction of hypertension with sorafenib has been seen as a biomarker, if you will, of response to sorafenib with renal cell carcinoma, and that those patients that appear to become hypertensive while on sorafenib seem to do better long-term in response to that therapy with regards to cancer control. So most of these side effects have occurred while on therapy or shortly afterwards. From a standpoint of endocrine issues, there have been a variety of pituitary issues that have been reported. These include immune checkpoint inhibitors that seem to be associated with, in a small proportion of cases, with hypophysitis, where they seem to have more effects on thyrotropin-releasing hormone, more so than ACTH or gonadotropin-releasing hormone. But all three of those have been, at least in case reports, have been affected. The thyroid itself has been associated with issues with second-generation BCR-ABL and other TKIs. This includes hypothyroidism primarily, but sometimes preceded by hyperthyroidism, including thyroid storm. So as a result, most patients on those agents, at least in adult protocols, usually get monthly thyroid screening. We've seen dyslipidemia, hyperglycemia with mTOR inhibitors such as sirolimus or temsirolimus, but also with BRAF and P13K inhibitors. And then there potentially are effects on fertility as well. So CML being a good example where, at least in the past, the paradigm requiring chronic or lifelong TKIs has made prediction of fertility or concern for pregnancies as a teratogenic agent concerning. People have looked at the safety of temporary discontinuation. If the new trials are looking at safely discontinuing TKIs, that may be less of a concern if those efforts are shown to be effective. At least in animal models, VEGF has potentially have effects on ovarian follicle development. And so with those agents, it may more remains to be seen, especially if they have growing use in pediatric populations. Certainly, with children still growing, we have seen effects on bone growth. So with imatinib, it's been shown to promote osteoblast differentiation and inhibiting osteoclasts, leading to unbalanced or disrupted bone metabolism. So this is a nice study coming out of a group in Japan that shows that growth deceleration was seen in prepubertal, or the panel on the left, children, but not in pubertal children with changes in height z-scores over time, with increasing effect the longer you've been on those drugs. And then retinoids have been associated with premature physioclosure with prolonged usage. This is just one paper, I think, out of Stanford that showed radiographically some of those changes in the patient on long-term retinoid use. And certainly immunologic issues have been one of the main side effects that we've seen. Again, I mentioned cytokine release syndrome, acute neurotoxicity, and obviously increased infection risk. So this has applied to monoclonal antibodies such as rituximab, where we tend to see just temporary B-cell aplasia for maybe about 3 to 6 months. And then with antibody drug conjugates, some examples being brentuximab, gemtuzumab, and inotuzumab, targeting different cell surface antigens, being associated both neuropathy and hepatotoxicity, sinusoid obstructive syndrome, the latter primarily because of osagamycin conjugate and liver clearance. There are bispecific T-cell engagers, or BiTE, with blinatumomab being the primary example, linking both CD3 T-cell markers to bring it into closer context with tumor CD19. And then, of course, chimeric antigen receptor T-cells, where there are obviously now various products, but primarily focused on CD19 ALL, although that repertoire is expanding. And then those have been associated with variable B-cell aplasia depending on CAR T-cell persistence. And then finally, novel donor or source transplantation, which transplanters will call the original immunotherapy. There certainly are issues with graft versus host disease as a byproduct of graft versus leukemia or graft versus tumor. And then there, of course, have been other instances of immune dysregulation in that context. So the question, I think, do these acute toxicities lead to longer-term impairment, either persistent or even as reemergent phenomena? Certainly, transplantation has been around the longest. And in our work using data in Seattle, we certainly have seen an increased proportion of patients still with late infections, even many years after transplantation. So this is a population-based data, so about 1,800 Washington-based transplant patients treated at Fred Hutch, primarily adult, but about a quarter pediatric. These were linked to state administrative data sets, including hospital discharge and death records. They were compared with a non-transplant group of mostly hematologic matched cancer survivors, and then also with the general population drawn from the driver's license file, or DOL. So you can see from these panels where we look at all infections, bacterial infections, fungal infections, and viral infections separately, that while the absolute risk diminished over time, there still remains an increased relative risk compared with both non-transplant cancer patients as well as the general population. And even years later, 10 plus years later, when chronic graft versus host disease and the need for systemic immunosuppression is likely markedly reduced. As an additional finding, we did also look at the number of potentially vaccine preventable organisms, and found that at least in the transplant group compared with the non-transplant group, that there was a significant increased relative risk of those infections even many years later. Immunologic disruption can also be associated with induction of new cancers. We know that the immune system has a critical role for cancer surveillance. Certainly, we've seen with chronic GVHD that there is a risk of new squamous carcinomas in areas affected, which may also be associated with inflammation. We know that with PTLD, there's a risk with immunosuppressive therapy in both transplant as well as solid organ transplant recipients. And then with BRAF inhibitors for melanoma, a quarter to 30% of patients in trials and cohorts have been noted to develop new squamous carcinomas within weeks. Interestingly, the mechanism may be related to underlying RAS mutations in these lesions, which the BRAF inhibitor then promotes carcinogenesis by pushing things along it. And then there have been increased reports of voriconazole in use of allogeneic transplant recipients as a fungal prophylaxis or treatment, but also with solid organ transplants seem to have an increased risk of skin cancers, which may be related to increased sensitivity of keratinocytes to UVA. So moving on to financial toxicity, this is just a case where this is one of the patients we follow in our survivorship clinic who had a history of relapsed ALL, underwent standard chemotherapy, and then had matched unrelated donor bone marrow transplantation, and then because of another relapse, had then subsequent CAR T cells. She's now many years off therapy and remains in remission, but still has undetectable CD19 positive lymphocytes. Overall, she's doing well, has gone back to school, but has long-term thyroid and ovarian insufficiency requiring lifelong supplementation. She actually has contractures from prior chronic graft-versus-host disease that partially limit her ADLs, or activity of daily living. And then she has long-term B-cell aplasia requiring monthly IgG replacement that at this point seems to have has not changed since day one. So the issues of financial toxicity of illness with cancer and other chronic illnesses has certainly gained increasing traction in both the lay press as well as in the biomedical community. And we know that the cost of cancer drugs, at least in the US, has increased dramatically. This is just one example over time where, again, the scale actually is logarithmic. And then even within childhood cancer survivors specifically, these are data from the Childhood Cancer Survivor Study published a few years ago, where there's a report significant out-of-pocket costs that are taking up more than 10% of their household income. And as a result, those are patients who have significant issues paying both medical bills, but also deferring care for other medical problems, right? And we're skipping tests and also increasing psychosocial stress and other financial concerns. And certainly this is applicable today in the COVID environment as well, where access to care is becoming an increasing issue. There's actually an issue earlier this year in the Journal of Clinical Oncology devoted entirely to economic issues. So if you haven't seen that, I encourage you to take a look at that. That's a nice resource, nice overview of the many issues that have come up. And then going back a little bit to CML again, and thinking about CML and tyrosine kinase inhibitor related outcomes, there have now been, of course, 2 decades of widespread use. There may now be sufficient time to begin studying long-term outcomes, but this remains a relatively rare disease in children. Even Philly positive or Philly-like ALL is also rare. In those populations, it's also hard to separate out the additional toxicity-related effects related to conventional chemotherapy, and for many of these patients, stem cell transplantation. We have started to look at this. Our group had access through a Stand Up to Cancer pediatric dream team effort with a large data set from a large US insurer. This is United Healthcare, also known as Optum Labs Data Warehouse, where we're able to look at CML mean analyzed costs pegged to $2017 over about a 20-year period almost. And so you can see from these charts that the annual costs have increased, even though inpatient and non-prescription costs have generally decreased. And that the primary cost driver here appears to be oral tyrosine kinase inhibitor costs. What this data set unfortunately doesn't quite cover is the late 2016 introduction of generic imatinib. That said, at least initial pricing of generic imatinib, while lower than the trade name product, was only slightly lower, not dramatically lower. Obviously, with increasing products and competition, that could still change. We've also looked at, in a slightly different way, costs over time. So this is the y-axis, the x-axis here is time since essentially diagnosis. You can see that chronic oral TKI therapy leads to pretty much sustained high healthcare costs. There's an initial peak in the initial 6-month period that's probably associated with diagnostic costs, but then you can see that especially the prescription costs don't really change and remain flat, or if nothing else, slightly increasing even 5+ years out. In contrast, the cost seen for patients treated for many other hematologic cancers in this study appear to decrease over time, where there's a peak in the first year, but then rapidly drops off as essentially treatment is completed. So you can kind of see this here, where we can compare the CML other hematologic malignancies and then a non-cancer general population sample. Again, this is all United Healthcare data, so it's insured population, where you can see that the CML costs are dramatically greater, and this is primarily driven by prescription costs. The predictors of immediate costs are not surprising. It's those patients that have been treated in a more recent era, because drug costs, even for the same drug, have gone up. Commercial patients pay more than Medicare, and I should mention that these costs are all the actual paid costs, not the initial claim costs, which we know that the initial claims that you see are oftentimes not the same as what actually gets paid out. So these are actually the paid costs. And then those patients who have more percent days with a tyrosine kinase inhibitor prescription cost more. And then those, of course, who've had a history of transplantation, and then increased healthcare utilization as measured by both clinic days and hospitalizations. It looks like there are some questions. I think we decided that we would try to go through these at the end. Is that correct?
Yes, go ahead and keep on going.
Okay. All right. So we've also looked at the same data set looking at outcomes themselves beyond just financial outcomes. And so when you look at the burden of outcomes across a variety of organ system categories using ICD 9 and 10 codes, compared with the general population, CML patients treated with TKIs, as well as those CML patients that went on to transplantation, there is, not surprisingly, a continuum where the patients with TKIs appear to have more claims related to all of these categories compared with the general population, but not quite as many as those treated on with transplantation. You can also look at comparisons by TKIs, where we compare imatinib versus later generation TKIs, in this case, dasatinib and nilotinib. The number of patients receiving ponatinib and bosutinib were too small to be analyzed separately. But those later generation TKIs appear to be associated with a slightly higher risk of both infections, primary infections, as well as infection subcategories such as fungal and viral, as well as circulatory and respiratory side effects, both in the initial year of therapy when dose adjustments may be happening more, but also even in years 2 through 5. And then I'll touch a little bit on, as I mentioned earlier, just on new surgery and radiotherapy methods. And so there's obviously been an increased use of less invasive surgeries over time now, such that laparoscopy and thoracoscopy are much more used compared with open procedures for both diagnosis and resective surgeries. For example, we also do see more limb salvage versus amputations. That said, the long-term benefits of these procedures are still not completely well characterized and are only just beginning to be described. So this is an interesting paper that we found about kind of orthopedic outcomes, where the left panel is what's called an MSTS score, where it's clinician assessed functional score, where you can see that those patients that underwent limb sparing versus amputation, based on clinician scoring, appear to do better. The right panel is patient-reported quality of life using the SF-36, where the differences between amputation and limb sparing appear to be not as dramatic, with maybe only slight differences in physical function and some of a few other of the dimensions, but for many dimensions appear to be quite similar. And then when you actually, in this study, asked patients to self-report their physical disability, there actually was no differences between groups. And so I think it just raises the question of, for long-term survivors of these procedures, even though a priori it may be obvious that certain methods may be associated with less morbidity, the longer term effects may be more equivocal. But again, this requires more study, and I think these are one of the remaining frontiers where much of long-term side effects are not well understood. From a perspective of radiotherapy, of course, over time we've seen 3D conformal and then intensely modulated and increasing usage of proton therapy. At the same time, the difference between radiation doses, this is an example from lymphoma treatment plans, in general would appear to favor in some of the newer modalities, where you can see that various organs may get less doses. However, that's not necessarily uniform, where you can see in some cases the thyroid or breast may actually receive more. And so when it comes to IMRT versus conventional radiotherapy, there may be a reduction of higher doses to adjacent organs, but in some instances, the amount of low dose exposure may actually increase. And so in this case, newer is not uniformly better. So looking at protons versus photons, protons, of course, have a much sharper Bragg peak and a drop off, and the advantage there is less exit dose, as can be seen in the example. At the same time, proton energy deposition in normal tissues is not as well understood as for photons, and they may be greater and have more biologic consequences. I know the radiation oncology community is looking at this actively, and hopefully in the next decade we'll have more information on this as well. There's already data, and this is one example from CCSS, looking at the dose-volume relationships, where those patients that received high volume, even at low doses, appear to have a higher risk of certain cardiac outcomes. At the same time, high doses, but at relatively low volumes, is also associated with significant risk. And that's just mentioned there as well. So again, these issues may also be relevant with IMRT and protons, even though the CCSS data is primarily older radiation methodology. So in the last part of this talk, we'll talk a little bit about how to advance knowledge of new agents, and certainly with the audience, hopefully this is more food for thought. There are obviously some challenges that are unique to precision medicine, and I'll give some examples of successful collaborative research. So one of the major challenges is with increasing molecular defined cancer, those diagnoses and treatments in the precision medicine era, even relatively common child cancers, will become exceedingly rare. So just with some of the leukemias as an example, we can break that up into lots of different subtypes, and a lot of that work obviously has been pioneered by the group at St. Jude. And simultaneously, there may be much greater heterogeneity of treatments, where a lot of these now basket trials being done across the world have matched various cancers, not by their cancer type, but by their molecular targets. Obviously, if these lead to oncologic efficacy, there'll be a need to study their long-term health and quality of life, but that will be challenging given the increasing heterogeneity of treatment. Obviously, most of the agents still being tested are in the early phase setting, a lot of times in the relapse setting, where a lot of these patients may not be long-term survivors, and the variety of additional previous treatments makes understanding the contribution of these targeted agents more challenging. But we're now starting to see more and more of these agents treated frontline, some examples being arsenic and retinoic acid, IMRT, proton therapy, as mentioned earlier, and certainly a lot of the surgical modalities as well. I'll have a slide in a little bit looking at the specific targeted agents that are coming on frontline therapy as well. And do these new agents even have an upfront role for some diagnoses? So there are some cancers now that have extremely high cure rates with relatively low toxicity profiles. So with the example of standard or low risk ALL, currently appears to be highly curable with conventional chemotherapy. We know that the late effect profile has been significantly reduced, such that long-term mortality, second cancer risk appears to be roughly similar to that of the general population, at least with maybe about 20 years of follow-up. these patients may still have more chronic conditions and more psychosocial burden. So it's not to say that these patients are completely thriving in the same way that someone who never had cancer might be. At the same time, it's always a challenge to test interventions in these settings where clinicians and families, as well as patients, may be less willing to experiment with alternative therapies, either shortened treatment durations and or alternative agents, with concern that treatment efficacy for the primary cancer may be reduced. So as a recent example of the improvement in both mortality and health-related outcomes, this is a paper published led by Stephanie Dixon, actually at St. Jude, again, looking at the CCSS data set, which they looked at treatment in that cohort based on treatment for the 1970s, 1980s, both standard risk and high risk, and then the 1990s, standard risk and high risk settings, where again, the standard risk treatment in the 1990s is fairly comparable to what we use nowadays still. And then lastly, the group, the lowest group is the purple with the relapsed bone marrow transplant. So you can see that in this really nicely done study, where you can see that the group from the 1990s with standard risk treatment essentially has the lowest risk of all-cause mortality, which is essentially similar to the general population, and also a very low burden of health-related conditions overall. Other cancer groups or histologies also are in this paradigm as well, where again, for example, the favorable histology Wilms tumor group has had very high cure rates for a long time now with just nephrectomy, vincristine, and dactinomycin. Where do they go from here? Certainly there's a possibility of investigating less invasive surgeries where perhaps the entire kidney does not have to be removed. At the same time, there's always the risk of increasing relapse rates in what otherwise would be a highly curable cancer. As promised earlier, certainly there are an increasing number of drugs that are now moving up to the upfront setting, not just in the relapse setting. This is just selected COG upfront phase 3 trials from the last 20 years, where in the number of patients and the histology and the targeted agent being tested, usually in a randomized setting. So a large number of patients being tested with nelarabine, which is probably the standard for a T-cell ALL. Bortezomib was also tested in that population, but it's probably not going to move forward. Tubonab is now being tested in the upfront ALL standard risk setting. Getting inotuzumab. Gemtuzumab was tested initially, kind of went out of favor, and is now being brought back in the newest AML study 1831, along with liposomal daunorubicin with cytarabine. And you can see a variety of different drugs being used across the different histologies as well, with solitinib with various low-grade glioma studies, topotecan, some of the Ewing study, and of course in neuroblastoma, or rituximab with Hodgkin's. The neuroblastoma group have obviously conducted many of the advances for specific for pediatric cancer with a variety of different targeted agents, ranging from dinutuximab to MIBG. Some of the challenges, of course, of relay effects research in precision medicine era. The clinical trials oftentimes have limited capacity to ascertain long-term effects. Oftentimes they're still limited to 5-year outcomes. This is particularly problematic for pediatrics, given the much longer potential latency of late effects versus older adults. We are starting to address that. For example, with AML 1831, that's again looking at CPX351, which is liposomal daunorubicin with cytarabine, in comparison with conventional MRC-based ADE regimen with desoxyzine added. The secondary aim is actually cardiotoxicity, and the sponsor is actually given significant funding to help us collect echocardiograms and blood biomarkers as a platform for looking at that, but also as a platform for longer-term follow-up with centralized echocardiographic measurements. Our own study, ALT11C2, which is attempting to do long-term follow-up of various primarily POG and DFCI protocols that looked at desoxyzine, mostly in a randomized setting at COG sites from the 1990s. Where again, we have very long relative for COG follow-up duration of 16 years with a mean follow-up age of, or mean current age of 28 years. But our own experience is, it's very challenging. This waterfall plot is basically the number of patients that are eligible at various sites, and then the blue shading is the proportion of patients that were enrolled. So you can see that for a variety of sites, the number of patients that can now be tracked down 15, 20 years later is quite small. Whereas at a few sites, we actually have very high enrollment rates. In one or two cases, near 100%. Our overall accrual only represents about 25% of those eligible. So related to that, relatively small numbers of patients on trials may also limit their power to detect rare but serious side effects. So some of these include, progressive multifocal leukoencephalopathy after rituximab, vascular thrombosis after ponatinib. Some of these have become only more apparent in aftermarket studies, but were not necessarily always apparent in the initial upfront clinical trials. And then related to that is, clinical trials really tend to favor younger patients, which also tend to may underestimate the true burden of toxicities. Just a couple examples here where, SEER Medicare data with trastuzumab seems to suggest a much greater cardiomyopathy risk versus clinical trials. There's even a signal that the cardiomyopathy risk may persist as opposed to resolve, which seemed to be what the initial clinical trial suggested. And then for nivolumab with Hodgkin, it's been shown that it may reactivate acute graft versus host disease in post-allogeneic transplant patients. And that was only noticed because afterwards, because the prior studies that initially conducted those studies excluded transplant patients as upfront eligibility. So just some examples of where collaboration is maybe helping us better determine long-term side effects going forward. This is another COG protocol looking at high-risk neuroblastoma. And as mentioned earlier, neuroblastoma treatment, as most people listening probably, has really evolved greatly in the last 20 years with significant advances in therapy ranging from both use of tandem transplants as well as a variety of targeted agents. And so this is a study that's open at about 75 COG sites where they are doing comprehensive in-person medical and psychosocial assessment. And again, the generation of patients treated since the 2000 really represents the first group of patients that are surviving in significant numbers into at least adolescence and young adulthood. And here, this is one of the nice examples of a COG long-term late effect study that had, up to at least COVID, accrued extremely well. And for those of us who have worked in COG, we're all very jealous of this study's accrual curve. And I think it points to a couple of things. These are mostly young patients still. Neuroblastoma as a disease primarily affecting infants and toddlers. And so as a result, even patients that are now in 15 to 20 years later are still adolescents or young adults that may oftentimes still be followed at COG centers or be more connected. And this is also a patient population that we know has a very strong patient advocacy network. And I think that also has helped get the message out through a variety of different mechanisms beyond what COG sites themselves can do. Other examples of collaboration include pooling data across various consortia. So this is one example where St. Jude Life data was pooled with additional CCSS data and a large data set from the Dutch late outcomes group, where again, we were interested in looking at anthracycline late effects, where this is an example where some of the first papers on daunorubicin came out in 1977. But here we're still generating new information 50 years later, where a lot of the research or a lot of the assumptions in the years since then have made some assumptions on cardiotoxicity equivalents being similar to hematologic equivalents or myelosuppressive toxicity, where daunorubicin was felt to be isoequivalent to doxorubicin. In another example, mitoxantrone was potentially only 4 times as toxic as doxorubicin based on hematologic side effects. So in a variety of work that we did where we combined our data from these various data sets, we're looking at daunorubicin versus doxorubicin in a pooled data set of 15,000 long-term childhood cancer survivors with about 270 heart failure events. We saw that in contrast to what we thought, daunorubicin appeared to be significantly less cardiotoxic in terms of relative risk of heart failure compared to doxorubicin. And then in a subsequent analysis where we now pooled 28,000 survivors with nearly 400 heart failure cases, the reports of mitoxantrone appear to be opposite, where mitoxantrone appears to be significantly more cardiotoxic than even the fourfold equivalence ratio we had been using. And so what resulted from these two papers was findings that what may be a more appropriate equivalence for these drugs is more on a 0.5 level for daunorubicin and maybe a 10-fold or greater risk equivalence for mitoxantrone in terms of cardiotoxicity. There's obviously lots of other examples of great collaborative work, and certainly I don't know if these lectures are going into the European, but certainly Europe with some of their multinational efforts have really pulled together almost a continent-wide data sets that they're now developing further, which I think will be an important mechanism by which to capture rare but serious late effects. And so going back to this Greek analogy, after Pandora's box was opened, what remained within the box? And that, of course, is hope, which we especially need this year, given everything else that's going on in the world. But with that in mind, I think, novel therapies offer the promise of increased long-term cure rates for child cancers and the promise of decreased late effects. But I think we need to be on the lookout. There may still be unintended off-therapy, off-target late effects, whether those are medical, psychosocial, or economic. But I think we can hope that these treatments will continue to improve, and as all of us who treat children with cancer, that the current and future generation of children diagnosed will have improved outcomes and improved quality of life. But I think it's going to be important for all of us that the critical that long-term follow-up of these population remains in order to determine if this is indeed true. So, these are really nice work, again, from Greg Armstrong, who's at St. Jude, as the PI of the CCSS, and a follow-up paper, Todd Gibson and Goli Mustafi Moab, looking at both mortality, which is the first panel on top, and then chronic conditions, which is the second panel, looking at improvements over the decades that the Childhood Cancer Survivor Study has enrolled patients from the 70s, 80s, and 90s, and you can see that there's a decrement with each decade, such that with the hope that patients now treated in the 2000s will have even lower burden of disease, and that the ideal goal would be that survivors long-term would have outcomes that are no different than siblings. And so, of course, this requires continued robust collaborative efforts across institutions and really across clinical trial groups and even countries, especially with rare but serious long-term side effects. Our group certainly has been interested and has used existing population-based administrative data sets as a cost-effective way to detect early signals for late effects, knowing that some details, of course, are not available from those methodologies. EHRs, certainly electronic health records that incorporate and allow pooling of clinical data elements, including pharmacy data, I think offer an interesting avenue for further research. And then finally, going back to this, slide, of course, we think about what happened then in that movie, and of course, what's happening in research, and of course, in the real world. Certainly, there are lots of advances that will lead us to a better, brighter future. And I think really the goal is we want to have our kids, especially leave our pediatric centers with their health intact, looking forward to their life to come. So I'll stop there. I think we have about 10 minutes. I just want to thank, a lot of this work, none of us are really experts. And a lot of this work came out of, Melissa had tapped a few of us to write a series in 2018 looking at this and other late effects topics. And a group of us got together to do our best to put together the available knowledge. So I'd like to thank our co-authors from that paper, including, I think, Beth Fox, who's now at St. Jude and was at CHOP before.
So Eric, thank you for that excellent lecture. We have some questions in the chat box, so I'll start with you. Are you aware of any ongoing efforts to systematically follow pediatric cancer patients treated with molecularly targeted immunotherapies? And in specific, wearing your hat as the chair of the outcomes committee at COG, what especially with COG putting in all these agents in frontline trials, what infrastructure is COG considering to monitor these outcomes?
Yeah, I think it unfortunately remains still a work in progress, as those of us who work in COG know, where efforts are still somewhat siloed between individual disease groups and in fact, even within individual protocols, where there's not necessarily always even common data elements. Now, some of the new initiatives, like the childhood cancer data initiatives, may help with that. It still, I think, remains a work in progress. And there are other efforts like Project Every Child and various registry-based efforts that are complementing the therapeutic protocols that may support or be helpful for sustained long-term follow-up. And certainly there's other efforts, that Smita Bhatia is leading within COG to put people on long-term follow-up tracing mechanisms so that people can be more easily found years later. But I think it remains a limitation, even in COG, that there's not necessarily a uniform NCTN-wide framework for doing this. But I think we're interested, but I think a lot of it is funding related. The infrastructure grant is quite tight, and so the ability to create a mechanism that allows us to do this for all those patients is at this point non-existent, or I shouldn't say non-existent, but limited in capacity.
So since many of these new therapies are used in high risk, technically a lot of them have relapsed, do you think we'll need to wait until more of the agents are moved to upfront therapy to really fully understand agent-specific risks?
I mean, I think the upfront therapy is going to be the easiest group to understand, especially in a randomized setting, because then you have a group that, say, got blinatumomab, but a group that didn't, but most of the other components of therapy are the same, and the vast majority of these patients are going to be long-term survivors. Then that's the study population that would be easiest to study. In addition, the upfront trials tend to have larger numbers, right? So if you have 5,000 patients getting randomized to blinatumomab versus a relapse study with 200 patients, the upfront study is going to be the one it's going to be a lot easier to study that population. That in essence is the reason that we chose to focus on desloxacitabine a number of years ago, just because those were all for the most part randomized study settings. But that said, it's challenging then to find those patients 15 to 20 years later.
And even with the agents that you described, it still seemed like a lot of it was focused on more acute and subacute toxicity. Are there any that have been in use for a long time, like the TKIs, where you can say, oh, these are acute and typically resolved toxicities? Are you at that point for like the metabolic or the endocrinologic toxicities for any of those agents? Do you have confidence that you would be able to counsel this is going to be a short-term issue versus a long-term?
Yeah, well, I think the TKIs and maybe the retinoic acids have maybe the most amount of evidence. And I know, Melissa, obviously, we, in the COG guidelines task force, we are trying to stay on top of those things. I don't think any of those particulate effects have sufficient evidence, at least at the moment, to have made it to be a formal entry in the late effects guidelines. But I think with additional time and maybe additional studies, the possibility is out there that maybe some growth effects with TKIs or retinoic acid may make it into the guidelines. That would probably be the ones that seem to be closest, at least from duration of usage, compared with some of the other agents that are newer.
Mm-hmm. Okay, so other questions. Are there specific agents you think should be of highest priority for investigations of late effects?
I mean, I think, it's a balance between what's been out there the longest, right? And then how common it is. We've had discussions about trying to study TKIs as a long-term side effect just because they've been used the longest of some of the agents we've shown. In addition to studies that are actively already ongoing, such as for high-risk neuroblastoma. I think the challenge with TKIs is, the number of CML patients or affiliate positive AL patients is quite small. And that's made it very difficult to generate, I guess, enough enthusiasm to try to find a cohort of maybe across the US, for example. And that's why I think, there are some potential other mechanisms and again, the US is not as well set up for this because we have no, national, infrastructure for this. But there are, other countries like Canada or some of the European countries that potentially could look at their population-based data, especially when they can link pharmacy and medical data and medical outcomes data, may be better positioned to look at relatively rare pediatric diseases, but that have had a fairly long history of exposure to certain agents.
Okay. All right, there's a question about, is there data on adherence of the long-term use of these medications? Is that related to late effects?
Well, at least the CML example, we know from a financial perspective that the financial costs of staying on your medications are associated with medication use. So then the more prescriptions or the more percentage of prescriptions that you appear to fill certainly is associated with greater costs. Other studies have certainly shown that adherence probably is inversely related to cost, right? So the more expensive the drug, especially out-of-pocket costs, tend to be associated with lower adherence, just because people are under the financial pressure in order to be able to stay on those medicines, which is a problem.
Okay, let's see, we're doing the time. Okay, what would be your recommendation on idarubicin dosing with respect to the dose of doxorubicin, or the other way around? Idarubicin has been considered less cardiotoxic but more expensive. Any comments?
Yeah, I think we tried to look at that, but the numbers were too small to generate different conclusions. And so I think the most recent paper, which was in JAMA Oncology, I don't think we found evidence that idarubicin at least was different from its currently published or widely used conversion equivalence formula. I'll actually just make a point that the equivalence formulas, at least for daunorubicin, that we reported as "quote unquote" new information, was actually, if you look at some very old studies from like the 70s and the 80s, that they actually suggested that daunorubicin should be about 0.5. It was seemed to be 0.5 cardiotoxic. And somehow that information, I think, got lost, and people no longer were aware of that. So in some ways, what we found was really kind of a rehash of really old information that got brought up again.
Mm-hmm. Okay, well, it's the top of the hour, so I'd like to thank Dr. Chow for his excellent talk and to close the official event. And we do have a few more questions in the chat box, and Dr. Chow has agreed to stay for a little bit to field those questions. So thanks to everyone for coming. We encourage you to look at the website where the lectures for the whole series are posted for your viewing. And please feel free to stay if you would like to hear the continued discussion. All right, Eric, a few more. Are there projects underway in order to use adults as mouse models for pediatric late effects, presuming, for instance, number of adults on TKIs and perhaps more end organ damage at baseline?
I mean, certainly, the information from adults is important, and obviously there's a lot of adult cancer patients who are going to be cancer survivors, and we need to know about their late effects too. It's not always easy, I think, to extrapolate the data from adults to children. Certainly, the growth issues are going to be in some cases unique to children, and we certainly have seen with some of the checkpoint inhibitors, for example, that the side effect profile seems to be greater in adults than in children. That said, there's been a lot more adults on those medicines than kids. But some of those effects have also been seen in young adults too. So I don't think we can assume that some of the autoimmune phenomena won't be seen in children, but may be less common, perhaps because of the differences in immune maturity in children versus adults. And that not to bring COVID into everything, but certainly with COVID, we know that there's a appears to be a differential side effect burden in adults versus children, and that may be related to kind of differences in immune development, as an example.
So something completely different. Is there long-term data looking at extended cost of individuals who've had limb sparing surgery? Did you see that in any of the literature that you guys reviewed for the new agents related to surgical techniques?
I'm not personally aware, but that doesn't mean that it's not there. I wouldn't say we did an exhaustive literature search on the topic, but I think that certainly worthwhile to look at if there are kind of, because I think, one of the issues with limb salvage sometimes is, you might then need additional surgeries for years to come, right? And so, so that may be one of those considerations where on face value, amputation doesn't seem to be preferred, but, over the lifetime of the patient, if you end up having to get, some sort of additional surgery every 5 to 10 years, as a 15-year-old looking ahead, is that something you really want to, is that really going to be preferred when you're looking back at it 30, 40 years later?
Mm-hmm.
There is just to put a plug in for CCSS, since I guess that's my other job. We are CCS. There's a group of surgeons in CCSS that have coded late surgery data, and so that will be kind of a new dimension of data or outcomes that we previously didn't have access to, and so that may start to at least give us more insight into some of those outcomes, and then that can potentially be linked to financial toxicity data or financial outcomes that CCSS has also been collecting in more recent years. So.
Okay, I have one more question. If you're brave enough to field, is it possible to know which patient will benefit and to give whether or not to give a specific agent? And the example was 2 patients who were given rituximab because of relapsed NHL, and one responds very well as a long-term survivor, and the other has acute toxicity. Is there data for any of these agents, that these newer immunotherapies that give you a profile of who's at higher risk?
Yeah, I think that's the holy grail, I guess, right? Where you want to target each patient with their exact treatment cocktail that would both, cure their cancer, but also have the least amount of side effects. And I think a lot of the precision medicine effort is kind of at least addressing or trying to address the first part, which is matching your cancer with the most most minimally toxic treatment regimen. That said, I think in that paper we put out in 2018, that there's this idea of precision survivorship too, right? Where the most ideal goal is to balance the upfront toxicity of the cancer treatment and cancer efficacy with their long-term side effect profile. And I think as we get more and more information, that I think will become more possible. And a lot of the treatment changes over time, such as Hodgkin's. Even this, CNS tumor, ALL, of course, have been driven by trying to find treatments that are both similarly effective, maybe not even more effective, but similarly effective but less toxic, right? So replacing cranial radiation, cranial-spinal radiation with intrathecal chemotherapy, reducing Hodgkin's radiation fields to smaller and smaller amounts, and then for those patients that appear to be good responders, maybe limiting radiation entirely. I think those things will come, but right now we're not there yet.
It'll be job security for everyone working in late health outcomes. How about that? A need to do that. Okay, well, that's the end of the questions. Everything else in the chat box is just congratulations and great lecture, and we really appreciate your time and that you took to participate in the series, and hope everyone has a good afternoon.
Okay, thank you.
Thank you.